So good evening, everyone. Thank you so much for today's session is going to be on ankle. So Upasana is going to be talking on uh, ultrasound imaging of anterolateral ankle injuries, and Dr. Nidhi is going to be talking on a similar topic, but in pathologies. Now, these are the two things which are something that you will encounter very often once you start doing muscular inversion injuries are an extremely common injury, not only amongst the athletes, but even amongst general. I'm sure a lot of us, who are attending maybe once in a while, we may have had an approach with this ultrasound imaging of ankle for the talk, you'll want to catch up with her. You'll find her this weekend at Patna, and she's doing the ankle boot camp. So if you'll want, please feel free to get in touch with her over there.
Good afternoon. In fact, I was preparing this talk for the Patna thing, but I didn't think that I have to present it in front of Nidhi ma'am and okay, it's okay. So ankle injury. Just to remind that our ankle has 3 joints. This is distal tibiofemoral osmosis. Then we have the talocrural joint where the ankle mortise will articulate with a talar dome. And we have the subtalar joint that anterior talocalcano-navicular joint, and that also articulate with a spring ligament. And in between there is a gap or gap which is the sinus tarsi, and this is our subtalar joint. So throughout the human being, especially for us, we from a quadrupedal primates, we turned into a two-leg creature, and from the low arch nervous system to a high arches 3-arch system. And these are foot so stiff that we are to fit and to run upright. So what is an arch stand? An arch of a foot is a curved structural form that supports the load from above and transmit the force to the adjacent structure according to the need, and that maintains the balance. The medial arch is a higher one that is formed by the calcaneus, talus, navicular, and tricuneiform and a bone. And the lateral arch is a flat. It consists of the calcaneus, cuboid, and the foot and feet metatarsal bone. And this is the axis of the foot that refers to the laterality of the foot bones. So that passes through the metatarsal head, but who will keep the bones in place, and the calcaneus and metatarsals form the pillar of the axis. Now, ankle injury, 25% and 46% of the during sports, intensive uneven surface, prior injury, poor physical conditions, or improper shoes. Whenever there is a force applied to the foot, then it stresses the ligament beyond the limit, and then lead to the tear or injury to the ligament, tendon, and bone injury. And this causes disruption of these arches. There is disturbed locomotion and uniform pressure distribution that leading to pain and deformity. So our role is to proper medical assessment of the site of injury and the severity of the injury, so that adequate and accurate correction can be done, and that can improve give a better life to the injured person. So if an ankle injury comes to you, then where we will put the probe, because it contains 26 bone, 33 joint, and 107 number of ligaments. We must understand that mechanism of the injury pattern, it depends on the mechanism of the force infection and the severity of the infection. Generated by a particular movement will propagate in a particular direction, and that put the structures on the way, make them prone to the injury. So depending on that, they describe 2 lines of weakness. One is the support line and other is the least strength line. And that divides the foot into the hind foot, mid foot, and the forefoot. And the syndesmosis or higher injury, high tibiofibular injury can be caused by the external rotation and hyperdorsiflexion. And the hindfoot and midfoot injury usually causes by low energy inversion intertarsal injury, and the forefoot injury can be caused by simple metatarsal injury. So they categorized the injuries into category 1 that contains the classic orthopedic fractures or the metatarsal piece, then the medialar, etc. Type 2 injury is the tibio-talar dissociation that separation of the tibia and fibula from the talus and calcaneus. So it will cause disruption of the ATFL, tibiofibular dissociation. I mean, the second category is tibiofibular dissociation, which is a high injury leading to anterior inferior or posterior inferior tibiofibular ligament or interosseous membrane. Category 3 is hindfoot and tibiofibular dissociation that will cause disruption of the ATFL, PTFL, CFL, and is hindfoot and midfoot dissociation. So it will involve the dorsal calcaneocuboid ligament, bifurcate ligament, then talonavicular ligament, and spring ligament. And the category 5 the forefoot, and that causes disruption of the Lisfranc ligament here. So we grade the TS according to the severity of the injury. And as we can see here, and it is important because it will indicate the return to play. Grade 1 or less than 5% tear or stretching, and grade 2 injury 5 to severe injury, which is less than 100%. That may need 1 to 2 weeks of returning to play or walk. Grade 3 may need 3 to 4 weeks, and high ankle need immobilization, 4 to 6 weeks immobilization, or maybe screw fixation or surgical repair. So before going to do any scan, we need a basic X-ray to know the basic understanding of the possible underlying pathology and its extent, and also it will give us the landmark to identify the ligament, tendon, and muscle. Usually, we don't have very major injury in case of ligament injury that comes to our scan, but we have to see the distance between the tibia and fibula. There may be overlapping on the bone, and sometimes we may have some small avulsion or C fracture. So when usually the patient come to us with a persistent swelling, disability to work or difficulty to work, but why there is a persistent swelling? We should understand it is because of the disruption in the capsule and extravasation of the fluid into the surrounding soft tissue that leads to a persistent swelling. But when it is like that, we have to understand that there should be some bony injury inside. So there is a comprehensive systemic approach for the anterolateral ankle, and we will try to go one by one. To start with, we always like to see the anterior recess, put the probe sagittal over the anterior recess, and then we can see the anterior recess, and that is a triangular space. As you can see here, it's a triangular space between the talus and the talar dome and the tibia, and it is filled by the fluid. We can do it in plantar flexion. It will expose about 80% of the talar dome, and we will to see if there is any injury to the talar dome or the overlying cartilage, or see for any effusion. Try to find out whether it is a simple infection or there is bleeding inside that may indicate some bony injury. Look at the extensor tendons in the transverse scan. Like in this case, there is extensive edema, and you can see it nicely there. In this case, for example, we can see a swelling, and there is depending on the skin just behind it, and also there is a swelling in front of the ankle, and we can see there is grade 1 injury in this part of the tendon Achilles. But as you make it long with and this is retracted back, and there is a long gap there in between, about 4 centimeter. We can see the transverse in short axis scan. You can see the retracted bulging of the proximal end, and at the distal end, there is no transition of the movement between these tendons. Once we see the tendons, then we move forward and going through the talonavicular bone, naviculocalcaneal bone, and the distal talometatarsal bone, tarsometatarsal bone. So while putting the probe in front, first ligament we see is a dorsal talonavicular ligament. It's a broad band from the dorsal talar neck to the dorsal surface of the naviculum. And it's the fourth most common ligament to get injured, as you can see here. And this is the ligament complex. And this is a grade 1 injury when we find some difficulty or confusion. This is grade 3 sprain. We can see the complete disruption of the ligament, and there is no widening. And there is widening of the joints in hand. And another case, most of the cases I got is the disruption of the talar end of the this dorsal talonavicular ligament. There is a gross bony injury. In this case, we can see periosteal stripping. And as we move forward, we can also see in the same case, there is disruption on the navicular feet with a avulse bony fragment, and we can see their lines there. And not only that, it also in the same line. So that will give us an indication how the force can propagate in some particular way and causing involvement of the ligaments in that area. Another case, it shows full thickness tears of the dorsal talonavicular joint and a swelling here in the tarsometatarsal joint in the same line, but it is not enough to give this much of fluid closer to it. So we make a transverse scan, and we can see there is complete disruption of the intercuneiform ligament bone. So we have to look to the adjacent area also whenever we find some tendon tear of some ligaments. So the next ligament is Lisfranc ligament. It's passing from the medial cuneiform to the base of the second metatarsal, and we have to place our probe in this direction. And it has basically 3 components: the dorsal, interosseous, and the plantar component. But usually we scan the dorsal one, and it maintains the Lisfranc joint alignment and strength, and connect the midfoot to the forefoot and support the foot arches. So in X-ray, we can measure the cuneiform metatarsal distance or intermetatarsal distance that should be less than 2 or 2.5 millimeter. So ligament, and we can see how it's effaced. It's a grade 1 injury to the Lisfranc ligament in comparison to the asymptomatic side. Another case showing complete disruption of the ligament, and there is widening of the space. Next, once we do it, then we go up to see the tibiofibular syndesmosis. Better we should have an X-ray. There we can see the talofibular clear space. This is the space between these 2 bones, should not be less than 5, or there may be overlapping of the bones that should not be more than 10 millimeter. So it's a oblique ligament that is passing from the lateral malleolar front longitudinal tubercle of the fibula to the tibial anterolateral tubercle. It's about 10 to 20 millimeter long or up to 3 millimeter thick, and it can involve in high ankle sprain injury that occurs in 0.5% of all ankle fracture. So for that, we'll place the proximal over the lateral malleolus and the distal end obliquely about 45-degree upward. Then we can see the distal and the ligaments. So it may contain multiple layers, and depending on that, dynamic study that will expose the ligament nicely. And this is the case, we can see a partial tear from the fibular end, as well as some fracture in the fibula that is evident. In another grade 2 sprain, we are not sure how much is the injury, but we can see there is swelling and some tears inside. And we do the eversion dynamic study, and we can see the partial tear involving the upper part of the ligament. This case shows very inhomogeneous and thickened which is not evident in the X-ray, but you can see a talar fracture there. And we do the eversion study like this. We can grab the calcaneum and do the eversion, and we can scan at the same time with the other hand. And then we can see some irregular tear line passing through the ligament, and there is also extravasation of fluid outside the tendon, outside the ligament. This is an ATFL injury with AITFL injury with a avulse bony fragment from the fibula, and there is widening of the joint space. Sometimes in acute injury, it's very difficult to find a dynamic study very carefully because it is very painful, but still it helps us to find out the tear, and also it can show some vascularity in that area. So after doing that, we'll go up to see the interosseous membrane because it may sometimes get involved. Going up, you can see the membrane between the two bones and look for any collection or hematoma, make it long and follow it down to see for any disruption or collection. Like for example, it's a partial grade, it's a grade 2 tear actually in front of the anterior inferior ligament, and it's extending to the lower interosseous membrane. After that, we'll move down to find the ATFL or anterior tibiofibular ligament. We'll just rotate the distal end to the talar neck, or we can put it directly from the great toe and place the probe there. Then we can nicely see the ATFL there. And it's as here, it's passing from about 10 millimeter proximal to the tip of the fibula to the 18 millimeter below the subtalar joint. It's going to attach to the fluid inside. This is the capsular fluid, and it usually get plants with the capsule of the ligament. And the pathophysiology, when there is inversion in plantar flexion, it has a superior band and an inferior band. And we can do the dynamic study like anterolateral test, as we all know, keep the leg fixed and place the foot in plantar flexion and pull it down. Then we can scan the area. And other than that, there is a modified study, Swanson modified test that would grab the calcaneus, then push it frontward. At the same time, our other hand will be free to scan the area. Okay, then there will be widening of the space and up to 10 millimeter accentuation or the increase in the distance, tibial distance, this fibula distance from the fibula and the talus up to 10 millimeter increase is taken as normal. So this is a grade 1 sprain. We can see there, and there is no increase in distance. This is little suspicious. We thought there are multiple tears we can see, but we do the stress test or the anterolateral test, and there is no talar translation of the talus or movement of the talus we can see. So we labeled it as a grade 2 strain. Another case, which is very well visualized with the dynamic scan. And this is also an acute injury. We can see a swollen ligament there. But with the dynamic scan, we can see the tear end at the lower end, and there is a accumulation of fluid. If we see a lot of fluid around the ligament, then there must be some leakage of the fluid, and we can find it. There is complete full thickness tear. Another case, we can see some fluid. So it looks like A
minute, Upasana. Can I request please to mute everyone? Husaina, if you're there, can you please mute everyone?
Yes, ma'am. Yes,
Husaina, please
yes,
mute everyone. Thank you.
yes.
And there is tear of the ATFL and with the lateral malleolus.
Go on,
Yeah,
Upasana.
passing in it's not correct. Yeah. Another case, we can see a small bony fragment lying in between the joint space, and there is disruption or irregularity of the ATFL. And we can see a very smooth large bone there below, but there is a small avulse fracture there. So I thought it's a bony fragment from the fibula lower end of lateral malleolus, but there is no such bony injury, and in fact need subfibulary, and of course it's very smooth. And finally we concluded avulsion fracture and presence of subfibulary, and it should not be confused with Hiller's avulsion tear. Just to look how important is dynamic study. This case we find some periosteal slipping and irregularity. With a dynamic study, you can see a large tear passing throughout the whole tendon, and see in fact a hematoma like this, and there is adjacent seed collection also. Then obviously there must be some tear of the severe tear of the ligament, and it was positive for Taylor-Till cyst. So when we finish the anterior tibiotalar ligament, then we will move forward from the lateral malleolus, putting it below the lateral malleolus and going forward till we see the three bones, the lateral malleolus, talus, and then we find the calcaneus, and between the calcaneus and the talar bone we find a gap, and this is the sinus tarsi. It contains very important structures like cervical ligaments, nerves, and some ligament, etc. But this is not for any collection there or any hematoma there that can suggest a subtalar bony injury. So once we do the sinus tarsi, then we'll move forward and we'll see the anterior tubercle of the calcaneus. This is another important point to see in lateral injury, ankle injury, because it undergoes because of the avulsion of the tubercle by the bifurcate ligament, which get attached to it, that occurs in plantar flexion inversion injury, or it may post-dorsiflexion inversion when the calcaneal process collides with the talus or cuboid. So we know that in the anterior calcaneal tubercle, we'll have the bifurcate ligament. That is a strong ligament which stem is attached to the calcaneal sulcus. Distally, it bifurcates to get attachment to the navicular and dorsomedial aspect of the cuboid bone. So we can put the proximal end on the calcaneal tubercle, then move little toward and downward, and we can find the both component of the bifurcate ligament. So this is the calcanocuboid component, and this is the calcanonavicular component of the bifurcate ligament. So this is a grade 3 sprain of the calcanonavicular component, and there is a calcaneal avulsion fracture as well. Another case of grade 3 sprain of calcanocuboid ligament and avulsed calcaneocuboid fracture. Here is a grid, as you can see, and compare with the other asymptomatic side. And there is also grade 1 sprain of the calcaneonavicular component in this case. So another case showing distal calcaneal bony irregularity, and you can see how nicely the bifurcate ligament avulsed out from the calcaneal end, and this is the X-ray showing the this is a avulsed bone fragment. After that, we will go to the dorsal calcaneocuboid ligament, little below. And in fact, these ligaments are said to be all in continuity with the bifurcate ligament. And in this case, we can have one complete tear ligament here. And there is also associated talonavicular ligament and AITFL grade 1 injury, and also bifurcate ligament injury. So there is always, it's important to look into the adjacent ligament whenever we find some ligament injury, as I said. If you notice, there is a loss of orientation of the fourth metatarsal here, and we can see the injured intermetatarsal ligament here. Even this say intertarsal ligament grade 1 sprain. Actually, the patient indicate where is the pain, and we must put our probe in that region. And definitely, in most of the cases, we find something below that. Then we go for the posterior talofibular ligament. This is the strongest ligament and very rarely involved and associated with complete talar dissociation. It passes from the posterior border of the fibula to the posterolateral tubercle of the talus. So we put our probe, the proximal end, at the posterior part of the lateral malleolus. Then if we move little up, then we can see the interosseous membrane passing from the talus and the fibula. And if we move it down little, then we can visualize this is the posterior tibiofibular ligament that got flashed with the talus bone here. This is a very strong ligament, and I have never seen involvement of this ligament till now. Then we'll have to see the calcaneofibular ligament that passes from the anterior border of the fibula to the calcaneus, about 13 millimeter distal to the subtalar joint. So this end, the fibular end, is very difficult to see because of anisotrophy, but we have to at the same time look at the joint space here, look for effusion or any synovitis or this site is used for the injection of the subtalar joint. And distally, it passes to the calcaneus lateral surface. So to see this fibular insertion, so that we this falls off, we can disappear, and we can see the anterior attachment of the ligament to the anterior part of the lateral malleolus. We can see it in transverse section also. Appears as an oval, very brass end-on appearance, and we can follow the ligament on transverse section from another attachment, and that will say about the integrity of the ligament. This is a grade 1 sprain. This is little confusing, so we did a dynamic study, and there is no separation of the joint, so it's a grade 2 injury of the calcaneofibular ligament. This is a grade 2 injury. Again, we can see the partial rupture, and in this case, we can see there is complete tear of the ligament with a avulse bony fragment, and there is no traceable ligament in this part. And we did the dynamic study. We can see there is a hematoma there, and there is a separation of the joint space. So this is really said to be in continuity that's combine these two and find both of them together. Little thing about the peroneal tendon, as you and Nidhi ma'am would say, ask about. And they have a single synovial seat about the supramalleolar region, and below the malleolus they have their own seat. They are bound by the superior peroneal retinaculum and the inferior peroneal retinaculum. As we move down, we can see the superior peroneal retinaculum here, and as we move up this portion, this is little part, as you go down, we can see it's become hypoechoic. This is not only because of characteristic of the fibrous cartilage, it changes little bit to the hyaline cartilage, and said because of this, it's become hypogenic. And you can see the peroneus brevis and peroneus longus, and the muscles of the peroneus brevis can move little down. And under retromedullary space, it's better to see in a longitudinal scan. Peroneus brevis is always closer to the bone. And if we move down on the lateral surface, you can see the peroneal tubercle, it's separate. The peroneus longus muscle, which lies posterior, and peroneus brevis will move anterior. Note the thick retinaculum of the peroneus longus muscle. So peroneus longus muscle is prone to the stenotic tenosynovitis in this area, while peroneus brevis is always prone to the compression type of injury on the retromedullary space by the peroneus longus muscle. And peroneus longus will passes posterior to the plantar aspect to get attachment to the first metatarsal base, and peroneus longus will move anteriorly and get attachment to the base of the fifth metatarsal. We must look to this portion because it's another common site of bone injury. Regular pattern of triangular thing that is get attached to the base of the fifth metatarsal on the plantar aspect, and this is the lateral band of the plantar fascia. So we do the dynamic study like this: put a pillow, then support the probe with your thumb and ask the patient to rotate the foot. Then we can see the movement of the tendons below the peroneal retinaculum, superior peroneal retinaculum, and there are gratings that will be, I think, ma'am will say. And whenever there is some injury, we can see in this case there are some bleeding, and then peroneus brevis is get compressed by the peroneus longus tendon here, and it's because of the dynamic mechanical insult at the fibular groove. There will be laxity of the superior peroneal retinaculum combined with mechanical pressure by the peroneus longus tendon, then eventually splitting of the tendon in against the south posterior edge of the fibula. This is one case. It shows it's just supramedullary region. You can see there is lax superior peroneal retinaculum, and peroneus longus and peroneus probing is moving subluxating into it, and peroneus longus is already causing compression, and there is a muscle belly there. And at the level of the lateral malleolus, we can see it's subluxating. There is thickening of the peroneus retinaculum. And at the level of the malleolus, again, you can see the thick peroneal retinaculum, the thickened peroneus longus tendon that is compressing and dividing the peroneal brevis into two tendons. And there is a muscle belly, which is not usually seen, so large muscle belly, so it of the peroneus brevis muscle, or there may be a peroneus quad. How the ligaments are moving in this dynamic study, and the peroneus longus is going in between the two divisions of the peroneus brevis. This is the distal peroneus brevis tendon, and then from the peroneal tendon along brevis tendon dividing into two, and we can see a large thicken and compressing. I just wonder, in this case, what is this portion? This may be the detached fibrous cartilage, fibrocartilaginous area, as you can see in the grading. So again, there is splitting of the peroneal brevis tendon, and causing chronic internal injury to the tendons, and its height is about 7, and the normal height should not be more than 4 to 4.4. And there is tenosynovitis of the tendon, and at the level of the peroneal tubercle, we can see both the tendons are dislocated anteriorly. The peroneus longus also seen anterior to the tubercle, and there is tenosynovitis, and there is disruption of the inferior peroneal retinaculum, which attaches to this tubercle. So because of disruption, the peroneal, we should not neglect and try to see, like we can see the bony fracture of the cuboid, then metatarsal base fracture, then head fracture, then the talar fracture, lateral malleolar fracture, calcaneal tubercle is another part, and of course there is a fracture of the fibula. Also the muscles, there is a disgram longus muscle, extensor digitorum brevis muscle injury. So finally, I always like to thank my teacher and the mass who come that change our life and our perspective. Thank you so much. Thank you.
Thank you so much, Dr. Upasana. I think that was a fantastic presentation. You covered almost all, I mean, I will not say all inversion injuries. Go ahead with Dr. Nidhi's presentation. And at the end of the presentation, I think we'll discuss, since both of these topics
if you don't mind, can I have few words on this? The problem with Upasana is Upasana will never stop being Rotudu. What you do, Upasana, stop being a Rotudu. Okay, over to you, Nidhi.
Presentation. कैसे कहता है Moହିତ? Wonderful cases. Wonderful. Well done, Upasana.
Thank you, ma'am. Thank you. Thank you, ma'am.
So, Ankit, we go on with our presentation?
Yes, ma'am. Yes.
Yeah? All right.
We should.
Okay.
So in case everybody has any questions, we will be having a discussion on the Dr. Nidhi's talk. Yes, ma'am.
So can you see my, right, okay. Full screen, right. So hi, once again, everyone, thank you so much for joining in to another webinar in MUS UCAM series. Thank you, Ankit. It's all Ankit's curating. After a fantastic presentation from Upasana, I will be more or less, I think, repeating of what Upasana showed, because I'll be talking only on peroneal tendons. The quick recap, Upasana has dealt with it. So posterior, the lateral compartment with muscles, peroneus brevis, peroneus longus. We have both these tendons running along the posterior surface, posterolateral surface of fibula. So immediately posterior to the fibula will be peroneus brevis, and from the peroneus brevis immediately posterior is peroneus longus. Peroneus brevis is anyway inherently a little flat tendon. So when you see, you would always find an oval compact tendon, and peroneus longus will always be a kind of rounded tendon. So from the tip of the fibula, 4 centimeters proximal, you have a common tendon sheath. And from the tip of the fibula, going about 1 centimeter down, they split and they are encased in separate tendon sheaths. They pass through the retromalleolar groove or retromalleolar sulcus. Now, it's very important to understand that here it needs, these two tendons need to be strengthened or supported. So we have what we call as a superior peroneal retinaculum. It's just a condensation of the aponeurosis and the fascia. So it has 2 limbs, superior peroneal retinaculum. There is a superior limb and an inferior limb. Superior then gets blended with the tendoachilles, and the inferior limb goes and attaches to the calcaneus. The more important part is that this becomes the most strengthening and supporting agent for both the tendons. First, we have inferior peroneal retinaculum. As you can see, it's just distal to the fibular styloid, and it supports for about 2 centimeters the distal tendons, both of them in separate tendon sheaths. And then it blends with what we call as the inferior extensor retinaculum. We have to understand the reasons why the peronei tend to become pathologically involved. So of course, we all know about the direct impact injury, and we know about the inversion injuries. But a more important thing that we have to understand are some congenital factors, which are actually more common. And as we are recognizing them in athletes, we come to understand that there are 2 factors. One is the depth of the retromalleolar groove. Sometimes there is no retromalleolar sulcus, or it's even convex. And the second is the laxicity of the superior peroneal retinaculum. So now what it does is that there is laxicity of the SPR or a shallow groove. When there is an overuse, that means when there is stress and a repeated stress, there is a repetitive subluxation of these tendons. And this repetitive subluxation leads to tendinosis, then splits and tears. And as Upasana also showed, sometimes there is the peronei, there are hypertrophy of the peroneus tertius or of also the peroneus longus muscle. So what it does, it is compresses peroneus brevis against the fibula or the fibular styloid and leads to tendinosis. And then there is a cascading of the pathology that develops. Having said that, I'm sure this anatomy was made more clear by Upasana. So this is just a quick recap. From here, we go on to the kind of pathologies. So there can be a tendinopathy or tendinosis and tendon subluxation dislocation, which is far more frequently seen as compared to other body parts. Tendon splits which lead to tears. And just for the purpose of description that we can put in our reports, this entire region of the retromalleolar, supramalleolar, and inframalleolar region has been divided into 3 zones. So zone A is where the tendons are lying just underneath the SPR. Zone B is where it is lying underneath the inferior peroneal retinaculum. And zone C just involves peroneus longus tendon that is at the level of the cuboid tunnel. And that is where the maximum tears of peroneus longus happen. All said and done, we have peroneus longus. We expect peroneus longus because it's the longest tendon to be the stronger tendon, but it's a peroneus brevis, short, stout, but it provides the maximum eversion power to that. So it is more prone to injury because it's strained more. So now we come to the tendinosis part, and here is a clip. So like all tendons, we will have focal thickening, degeneration, softening. But more importantly, in peroneus brevis, what we find is a change of the shape also, which is the first hint that there is some sort of a softening or a degeneration taking place. Now here's a video clip, and this video clip, we are going from proximal to distal, peroneus brevis, peroneus longus, peroneus brevis forming, and now you see the change in the shape. From a flattened shape, it becomes comma-shaped, and you can see all the degenerative changes. There is, of course, a thickening that you can perceive. So we go on this. So this video clip is the first thing because of the change in shape that it catches your attention. Having said, we are right here on the static gray image from this, as you can see here. And these are the cystic degenerative changes. You can see softening, you can see hypoechogenicity, and there's this change in shape. Now, it almost seems as if this change in shape is going almost circular, but it isn't. So we have to make sure that this is not given as a tear of the peroneus brevis. This is tendinosis with a comma-shaped structure that forms or a boomerang shape. Not only that, the structure that you see here are some fibers of the lower end of the peroneus longus, which sometimes accompany and they go deep into the, we call it a fibro-osseous canal. So this fibro-osseous canal, which has got a superior peroneal retinaculum, and the base is formed by the calcaneofibular ligament and the posterior tibiofibular ligament as well. That forms the base. This echogenic is, of course, the SPR of the fibro-osseous canal, but this triangular echogenic structure that you see, which attaches the SPR to the fibular styloid, is what we call as the fibrocartilaginous ridge. And this is one of the very important components when we are dealing with the tears of the SPR and the dislocations of the tendons. Of course, when there is a tendinosis, we do our vascular studies, and we see there is an increased vascularity, which indicates quite a lot of inflammation. So I'm just going to go to my next slide. The next thing, so you have tendinosis that are sitting in peroneus brevis. Peroneus brevis is more involved in tendinosis than peroneus longus for obvious reasons because of the compressive it takes during eversions. So the next step is that there is a small intrasubstance tear that develops. The shape changes, and you can see this is an intra-op image where this is partial, this is a complete tear, but a small segment in the retromalleolar region or in the just inframalleolar region. The vascularity, of course, that is not we're going to talk about, but the accompanying fluid. Now, this is a very important concept that we need to understand that when we are talking of athletes, we are talking of overuse syndromes, we're talking of elderly people. We have a little bit of fluid that comes in all the joints that take a lot of strain. So we're talking of ankle, and you will come across in elderly people a little fluid in the dorsal recess, in the common peroneal sheath, or even sometimes in the lateral gutter. And that should not be misconstrued as something of a pathology. So where do we go from here? That is, of course, the boomerang shape that you see. So if you come across something like this, where this is peroneus longus, peroneus brevis, and a little bit of fluid that is there, you need to really consider that this is not really pathological, and you can always call the patient for a review study. We have to adhere definitions, and the definition is, again, the same that we have in long head of the biceps tendon. The fluid has to be circumferential. The tendons have to show the collateral damage of being either tendinosis or a tear, and the maximum diameter has to be 3 millimeters or more for us to say this is pathological effusion, and we don't make an overkill by our diagnosis. So before I go on to this, I'd like to come back to the sonoanatomy. What, of course, we see here is that this was an acute injury, a lot of malleolar region, and the tendons, which are showing a little bit of heterogeneity. There is a little bit of synovial. Here is the SPR, or the superior peroneal retinaculum. So there's a nice nerve tunnel that's getting formed. And this, of course, again, is the fibrocartilaginous ridge, which is a very important component again. And I'd really like you to remember this configuration for you to evaluate if ever you come across a tear of the SPR. The normal configuration of peroneus longus, peroneus brevis at the fibular tip of the fibula. This is intramalleolar region. And this is how you would see in a static grayscale the two splits of the peroneus brevis. These are hemitendons that form. And there's just a kind of migration or invagination of peroneus longus that is taking place with a little bit of the peritendinous fluid, which accompanies the tendinopathy. This is, of course, an intra-op image where you can see the two hemitendons and the longus migrating through these hemitendons. So this is a video clip here, and I'm sure you will be able to appreciate here how that, of course, is the peroneus longus. This is one hemitendon, another hemitendon, and of course, a thickened SPR, peroneus longus, one hemitendon, another hemitendon, which is going on to show that this is a complete tear of the peroneus brevis with migration of the peroneus longus, which is also showing tendinopathy, fluid into the two hemitendons. And this is kind of evaluation on a dynamics, just in case we make the tear worse and we that split and see the and to demonstrate the split of the peroneus brevis. When we come to the applications, peroneus longus, tendinosis and tears, we're talking peroneus brevis. So when we are talking of longus subluxation, this is a Reichen et al. Classification, and there are two diagnostic criteria that we have subluxation, intrasheath subluxation. So one is that it has to have an intact superior peroneal retinaculum. And the second is that in type A and type B, when we subclassify, we have to see what is the status of peroneus brevis, whether it is intact or there is an associated tear. So I bring you to this diagrammatic representation, and you see here that this is a normal configuration. In the retromalleolar groove, we have the tip of the styloid here, the cortex. Close to the cortex, in the posteriorly, we have peroneus brevis and then peroneus longus, the fibrocartilaginous ridge, which is attaching to the superior peroneal retinaculum. Now, when we are talking of A, you can see that this entire configuration has changed. And what we have is that the peroneus longus tendon is actually invaginating between the cortex of the fibula and the intrasheath type 1 subluxation of peroneus longus. Peroneus brevis. So what happens is that peroneus longus actually is between the hemitendons of peroneus brevis to come closer to the cortex of fibular styloid. So here are some of the video clips. I would really like you to keep your eye on the fibrocartilaginous disc here, or the ridge here. And this is how the click or the jump of peroneus longus in between peroneus brevis. So what you can see here is, of course, a thickened SPR, but intact. So this is a type A kind of peroneus longus subluxation. Now in this second clip, as you can see, this is a little more aggressive peroneus longus, which is placed between peroneus brevis and the cortex. But more importantly, as you can appreciate, that it is actually pressing there. Do you see how it is just pushing that SPR away of laxicity of the SPR versus where this was nice, tenacious, and snug. So laxity to the intrasheath subluxations, tendinosis, tears, and the pathology we understood. And this is the only way that you will be able to demonstrate whether this is a lax SPR. From here, we go to peroneus longus tear. Now, peroneus longus tear individually are never seen. They are usually with the peroneus, again, was an acute injury. There was a peroneus brevis tear also, but associatedly on a grayscale stacking imaging, we were able to see an peritendinous area. And this diagrammatic representation shows why it is that we say the peroneus longus tears at the level, and this is a cuboid groove where the longus actually enters the plantar area and then takes a kind of at the base of the first metatarsal. And this cuboid groove, with this cuboid groove, and if there is an osperonium that is sitting in the peroneus longus, is an injury. Here is a dynamic scan just to show that how we were able to demonstrate that level of cuboid groove. You could see the peritendinous fluid that was actually making its way into the longitudinal split, extending a little way into the plantar region as well, called as the dislocations of peroneus longus. And that is where we come to a classification again, which from grade 1, 2, 3, and 4. Grade 1 is when there is just this stripping of the SPR, doesn't really go away, and fibrocartilaginous ridge is intact. This is right there, and slips anterior to the fibular styloid. The second is, of course, where they get avulsed from the fibular styloid. Then there is a bony avulsion also. And grade 4 is when there is a distal. That means it avulses from the calcaneus. Again, that triangular fibrocartilaginous ridge. And this I have taken from the net. I really couldn't find my own study, but on the C, the peroneus longus and peroneus brevis in a normal configuration, but as soon as the dynamic scan has been done, anterior to the fibular styloid. Now, this is one of the cases, and I hope that I will be able to convince that ultrasound is a great modality to diagnose and give grading of the SPR tears. Now, what we actually saw here was, again, a tear of the peroneus brevis. This was just distal to the inframalleolar region. And of course, this is a peroneus longus tendon. A lot of tenosynovial proliferation, a lot of vascularity. So there was a huge lot of tendinosis. This patient came in within a week of an eversion injury, And this is a thick SPR that you can see. Along with this, I was able to also see that there was a calcaneofibular ligament tear. So it was a very complex ankle injury that was sitting here. Now, this video clip is just to show that how we were able to diagnose the tear of the peroneus brevis, which was associated with the SPR tear also. And as we are going from distal, that was a peroneal tubercle, we are going proximal, the two hemitendons with the peroneus longus, just in the inframalleolar region. And as we go, of course, there was a lot of tendinosis, a lot of synovial proliferation as we went proximal. But this is where we were able to demonstrate, this is the distal end of the SPR, which is attaching to the calcaneum. And as you can see in the proximal region, there was complete tear of the SPR. There was no fibrocartilaginous ridge that we could see, and a lot of synovial proliferation. And we were able to demonstrate the intrasheath subluxation with a tear of the SPR. So this was a grade 2 kind of injury where SPR was taken off and there was avulsed and the fibrocartilaginous ridge was also taken away. Only this, so we were unable to really demonstrate the dislocation of peroneus longus, but that could be because of the encasement of the entire peroneus brevis longus complex in this very thick synovial proliferation, which in that acute injury was probably, it was just catching hold of them. That is what I feel, but a subluxation or a dislocation, both are possible with the cartilaginous ridge. So with this, I come to the end of my presentation, I think, and thank you very much for your attention. Thank you, Ankit, for organizing it. It has been a wonderful, wonderful journey with all the UCAM delegates and now, of course, our colleagues. So thanks all very much for your attention.
Okay, so thank you so much, ma'am, for this wonderful presentation on such a focused disorders. So I want to ask that when you have a reference what do they actually tell you that you're suspecting a peroneal tendon pathology and you just look for it, or is it that they just are they sent you just as a cause of what to determine that what is the cause of posterolateral ankle pain?
I will really impression. I just got yesterday a prescription which said ultrasound shoulder, and it said tear supraspinatus, infraspinatus, subscapularis. I mean, everything was there in that. Clinically, that is what they went. It was just a wide, full thickness tear. Today, I got a patient for ankle, nothing. It just said ankle ultrasound. Now, it was entirely up to me to see where. I don't think that our colleagues really have graduated from that MRI, because so there are multiple sectional images that come and the radiologist reads them and give them a diagnosis. So that focused clinical interpretation, feeling that orthopedicians really don't want to put their hands. They look at it, agar हड्डी टूटी है एक्सरे के अंदर, चलो प्लास्टर कर
Okay. So yes, anybody else has any questions? Ma'am, yeah, please.
Nidhi, excellent one. Excellent demonstrations. Your videos were too good.
Thank you, man.
Yeah, both the presentations were excellent. We could see possibly all the pathologies that one can encounter. So,
thank you, sir.
Yeah, it's a good.
So, do you give, Dr. Nidhi, do you give that classification, Ogden's classification, when you do you always try and fit it into that, or you just describe it and leave it?
So what happens is, what happens is that, see, there are some very popular classifications which everybody knows, and we are on the same page when we are talking of those classifications. These classifications that we put on our presentations are more for explanation so that everybody can understand what structures we are talking about and where we are going with the grade of severity in our own minds. Normally, I give type A, type B. Lately, I've started doing that, where I give that it's a type A type, but we have to give our description. We have to put it down. I draw, I make diagrams. That is one thing I learned, that if we don't give diagrams, one of the tricks that helped me settle, either I have to give a phone call and explain, or I give a diagram. So a type A, type B, if I'm giving, or if I'm giving a grading. So if I write down there that there is a stripping of the peroneal retinaculum along with that of the ridge, and I put as grade 2 injury, that just helps me to, when the patient comes back again, to recap where I was with my review interval studies. So it just helps me in my own interpretation of findings. But yes, I do. I do give classifications. I do, even in my x-rays, I give classifications. For my plantar spurs, I give classification type A, type B, whether it's going into the muscles. So on my x-rays also, I give classification. So in ultrasound, yes, I do classification. It helps me. It helps me in my own review studies.
One of the comments, if on the plain X-ray, a patient who has an inversion injury, and if you want a plain X-ray, if you see the wide separation of the peroneal tubercle, not peroneal, os peroneum, then you should suspect, and you must look for the peroneus longus there. That is the indirect sign. So reading the X-rays of paramount importance, we must know. Sometimes that is a clue to the underlying soft tissue injury. So that's one area that one should keep in mind.
No, so like we have what we call as a flex sign, where the fibula, the lateral surface of the fibula gets avulsed. And that's a very strong pathognomic sign for avulsion of SPR. And we just leave it.
I think, you should have multiple X-rays to look for the avulsion fracture, because these are very small fractures, and unless you are really good observer, and if you have a good quality X-rays, then only you will pick up.
Right.
That's very important.
And that is one place
Yeah.
where I just forgot in my
Mhm.
presentation to mention, and this is really
Yeah,
for
otherwise,
everyone's attention, that the subluxation that we talk of peroneus longus, and sometimes they are asymptomatic and sometimes they have no clinical significance. They are just a little lax SPR, and you have the clicking sound that is coming, which doesn't really need fixation. So the intra-sheath subluxation is not always clinically very relevant, particularly
yes.
the type A kind. So these were my cases.
Yes, yeah,
So
right.
these were my
So many
cases.
times
My
we see
ankle
patients
sublux.
who voluntarily yeah. We see so many times patients, they themselves come and they to show that I can voluntarily
देखो ऐसा हो रहा
sublux
है.
my the peroneal
Yeah.
tendons, and if you do, so they show you, that's the thing.
They show, and
And one more point is, so retromalleolar groove, if you see more than 2 tendons, most of the time you think about the possibility of the tear of the brevis. But one anatomical variant is peroneus quartus,
Quadratus.
which is usually present in about 22% of the patient. Yeah.
Totally
So
agree,
that's
sir.
one possibility you should try to, and in that case you have to trace this tendon, because the attachment of the peroneus quartus is at the calcaneal level, while the brevis and the longus, because the almost 20% of the patient may have the accessory tendon within the retromalleolar groove. So, that should be.
Yes, sir.
Anything else? Yeah.
I think one great point what Upasana brought about was, the technique to look at the posterior talofibular ligament.
Yeah, that was wonderful.
Yes.
Yeah, we don't generally cover that. But
Yes.
it is possible to see it on ultrasound.
I had seen, always we say that we don't see the posterior inferior tibiofibular and the posterior talofibular ligament. But in one of the conferences, Martinoli showed how to look at these tendons, where he performed the examination in a standing position, or a patient was put into the squatting position, and you can look from the posterior aspect. I still remember he showed how to look at the posterior inferior tibiofibular. Yes,
वो सबको दिखाता है, उसको बहुत अच्छा
how
लगता है दिखाना.
Yeah. Because if you look at the literature, most of the time people say that these are the 2 ligaments that you don't see on ultrasound. But he showed how to look at it, and of course it's the same. Once you see that, you have to just connect the lateral malleolus with the posterior medial tibia, and you'll be able to see the posterior inferior tibiofibular ligament, and of course the talofibular ligament. But I remember him showing how to look at this.
He does. Enjoys that. Upasana, I needed to ask you this.
Of course,
so you said,
Upasana.
Upasana, you said that
presentation was excellent.
Was very excellent, sir. Those intertarsal ligaments were so beautifully shown. Upasana, you said it is the second ray, which is the alignment ray is the second ray. But as I remember from my anatomy, it's the third ray. Are you sure? Anybody to comment on that? I thought it was the third ray. The third metatarsal goes through the mid of the talus and then goes through the tibia. So I don't know. I remember it as third. Does anybody have any
axis of the foot, sir? Axis of the foot.
Axis of the foot.
Okay.
I thought it was the third ray. I mean, that's what I remember from my anatomy. I could be wrong. I'm going to go back. But if anybody has any opinion on that, it'll be great to clarify that is it the second or the third ray? Because from my anatomy, I remember it to be the third ray. It goes to the third metatarsal. Okay. And then that is what goes through the head of the talus. Why does a second or third, but mere ko third yaad hai?
Second likha hua hai, ma'am.
Second है
second hand.
Middle of the head of the second metatarsal from the calcaneus.
Okay, fine. From the
calcaneus, matlab from the back. It's posterior superior edge of the calcaneus to the middle of the head of the second metatarsal.
Okay. So I'll come back on the group. मैं एक बार देख
It's not
हाँ एक बार confirm करने का. And there was just another question that I wanted to ask was that when you showed the sinus tarsi, you had your talus and you showed calcaneus, and there is this. So I would have thought that it would be if placed transversely across. Then you see the two dips and you see the talus and the calcaneus.
No, it's put transversely from the inframalleolar region, and I am just moving forward. Yeah.
Correct. From the inframalleolar region, but you stayed in a long plane. I thought if it would be a little oblique, then you would be able to see talus here, calcaneus here, and that dip of the sinus tarsi.
Yeah, because I have already seen the ATFL. So I am from the fibula lateral malleolus to the talus. Already I got to this two.
Okay,
then
okay.
I move anteriorly to the
calcaneus. Okay, I didn't see that. All right, fine, got it. Perfect. Any questions, Dr. Pawar, Dr. Ketkar, Gina, Rolly? Nimit, thank you so much once again.
So, Dr. Upasana, when you have a patient with ankle injury, do you have a pattern or do you have a checklist for the structures that you will see? Or do you kind of, ask the patient where exactly is it paining? You have a look at it and you just kind of note down the findings. How do you go about? What is your approach?
Actually, Dr. Ankit, usually patient give a history, that is very important. He will repeatedly showing you the place, I have pain in this portion. So definitely I will give more stress to that part, but I have to see all the structure at least. I think other ligaments also I used to see, but definitely when the patient says, in my experience, till now, whatever I find, it mostly depend on their history, because they just use their finger to point out the portion where there is more problem. Most of the cases.
I agree. Yeah, I think a lot of times, at least for me, my ankle examination protocol is going to vary depending on what is the clinical presentation of the patient, where is the patient's pain, and what is the clinical scenario? Is it, if it's acute inversion injury, I'm going to just look at the static images, look for hemarthrosis, but if it's like a more chronic injury, lateral ankle inversion, then I will also do a dynamic scan to look for any anterolateral impingement as well. And of course, like you mentioned in all your talks, it's a good idea to have a look at the mid-foot ligaments as well, because on your standard ankle x-rays, the AP and lateral, you will not pick up those mid-foot ligament injuries. So in fact, if you have those bifurcate ligament and calcaneopuboid ligament, it goes into the category of a high-grade ankle sprain any which way. So those injuries which are missed, often the patient has chronic ankle pain and not doing that great.
So ESSR protocols mention that you have to look at the bifurcate and calcaneopuboid ligament. It's a part of the, I think, ESSR protocol. So I think whenever you are evaluating, you need to look at these ligaments too. And besides that, I would say in a non-traumatic conditions, if the patient has a pain, you also should look at the sural nerve and the superficial peroneal nerve. In a non-traumatic conditions, where patient comes with the pain along the anterolateral aspect of the ankle.
Of course, one thing that I found with ankle was that, like in shoulder, there are so many referred pains, but in ankle, one thing is that the target sign is so specific. The patient is, they are not referred. And so the patient is just so sure where the pain is that you can really go for a target study and give a diagnosis.
Yes, that is for sure. Yeah, but so in anterolateral evaluation, as I said, if it is a non-traumatic condition, then you have to look at the nerves also. But of course, I think, as I said, ligament is a primary source of pain in the ankle region, So that's
even so Baxter nerve is also not so infrequent. Baxter nerve.
Baxter, yeah, but that is more on
Fantastic.
medial side, right? Baxter is,
Deep vein.
yeah. So, yeah.
So coming to nerve, as far as ankle inversion injuries is concerned, the deep peroneal nerve has this, tendency to become,
Okay.
get stretched, and it can cause a lot of chronic ankle pain. In fact, a lot of these patients, for months and months, they'll be having soreness in the ankle, and they are labeled as CRPS.
Yeah,
And somehow these patients are never happy. So this, we have seen this. I mean, I will not say many times, but we have seen it at least more than 4 or 5 times, wherein the deep peroneal nerve does get stretched with the ankle inversion injury. And typically, the patient has soreness and they look like CRPS actually on a long term.
So then what is it that you're looking for there? Are you looking for entrapment? Is there like a notch
No,
sign or
so
something?
so as a nerve, the deep peroneal nerve passes over the neck of the
Rectangular.
talus, and it's actually below the extensor digitorum longus. Actually, that's where you'll find it. And
Correct.
what you see is that
Hallucis.
the nerve will be slightly thickened, like stretched, but not discontinuity. And the patient said, "Mera ankle inversion hua, but doctor, my ankle is never normal. Beach mein it swells up and it settles down." And in fact, they will show you the pictures. They have those pictures and they will show you, "Doctor, this is the picture." And then you actually, yeah, it looks kind of swollen. You see some veins which are swollen, but yeah, it definitely
Right.
looks abnormal. And these are the patients. And while scanning, maybe the ATFL has healed and you know that, yes, that is the kind of pain that the patient
So what
has.
is the pathophysiology? I have never come across.
So this nerve, see, as it passes over the talus, it gets
Right.
stretched. When there's an ankle
Yes.
inversion,
Okay.
and this nerve, it is kind of held together at the level of the that. So all that ATFL has settled, the hematosis has settled, everything, but somehow the patient is not happy.
Right.
So. And then the patient has been labeled as a CRPS.
Uh-huh.
So if you find this nerve, then you know that this is a type 2 CRPS, which is, I mean, you have an identifiable cause for the CRPS.
Good
So,
point.
yeah.
Okay.
So it should be seen in chronic cases, basically. If it's not.
Yes. In chronic, in patients with chronic ankle pain. Yeah.
Chronic ankle injuries. Correct. Absolutely. I'm having nowadays a small child come of 8 years, and he had some injury to his forefoot, mid-tarsal region. And somehow I have this feeling he's not malingering, and he's continuously complaining of pain and a little bit of swelling just on the dorsum of the foot, and couldn't find anything last time. I think I'm going to call him again and see because he's a kind of footballer, one of those 8-year-olds who just have to get out in the sun and play. So I think I'll call him again and look for this deep peroneal injury, if at all there is. Because it's exactly the point that you're saying. Just at the head of the talus, that's where he has a little bit of swelling and complains of pain at that point. Let me call him. Right. I'm very intrigued. Okay, I'll let you know.
And a thickened nerve from the pseudoganglion of the deep peroneal nerve. There's something called a pseudoganglion. So just still to that, that's where you'll see that thickening of the nerve.
Right.
That is one thing we need to differentiate it from.
Perfect. I'll call him. Let me review him. Lovely. Great.
Yes, great. So, any other questions?
No, I think we're happy.
Great. So, thank you, everyone, for joining in. Thank you, Dr. Upasana. Thank you, Dr. Nidhi, for these wonderful presentations. And yes, I think this has been a great learning experience for me as well. And I think a lot of everybody, I'm sure, would have found this very interesting. So if you guys want to present some case or talk on something, feel free to get in touch with me. And let's see interesting cases for discussion. And I'm sure we can learn from each other on these webinars. Yes.
Thank you, Ankit. Yeah. Thank you, Upasana. Lovely presentation. Killed me. All the best for Sunday. The boot camps and Gina are going to do us proud. So thank you very much, Upasana.
All right. Excellent lecture, Dr. Nidhi and Upasana. Speechless.
Really good, Upasana, too elaborative.
तुम बोली मुझे लगा तुम बोलोगी ही नहीं. तुम बोली.
उपासना ने तो डरा दिया, इतना सब बताया.
अंकित भी डर जाता है, और आज मैं जब अपना प्रेजेंटेशन बना रही थी मैं भी बहुत डर रही थी. मुझे लग रहा था क्या इसमें और रंगीन करूं. So I started doing that रंगीन हाँ उपासना मैंने उसको रंग करा, वो जो मसल प्लेन क्या करूं, this highlighter, मैं उपासना तेरी पिटाई करूंगी, and I just couldn't get that highlighter away. Somebody tell me वो highlighter आता है तो उसको हटाना कैसे होता है. I'm not going to do it again. But Upasana, absolutely perfect. Very beautiful.
Yes.
And you know what is one thing that I'm going to carry home today from your presentation? That these ligaments should be looked in a real magnified view.
Yes.
I mean, whichever probe you're using, if you're going to keep looking it in this frame and not magnify it, you will lose it. Perfect and very, very beautiful. Loved it. Loved it.
Thank you. Thank you.
Great.
Okay.
Now Upasana
right.
can now sleep in peace. You know, we to kal to you're traveling, na? Maybe
हाँ.
after tomorrow
She's going to travel, a long travel for both of them.
Great.
Hello.
Great.
Okay.
All right.
All
Good
right.
night,
All
Ankit.
right.
Thank
Good
you
night,
so
everyone.
much. Thanks,
Yes.
everyone.
Bye.